Okay, good evening, everyone. Welcome to my evening session on women's sexual wellness. I'm Dr. Ann Scott. I'm a urologist at the Urology Group, coming to you live from the lobby of our Fairfield office. All right, here we go. We'll get underway. So here I am. I'm actually one of the newer urologists in the group up here. I've been back in Cincinnati now for about 9 months. I've been in private practice in Tuscaloosa, Alabama for 10 years. We moved back up here to be close for family and for kids. So really excited to join the urology group. I'm a general urologist. I started doing everything in private practice, and then I pretty quickly narrowed my focus to just taking care of women and focusing more on women's issues and doing less of the big cancer surgeries. And so that's really what I've been doing probably for the last 5 years or so now. So, all right. Well, our talk is going to take us on a kind of whirlwind tour of the female urology world. And we kind of did it through a focus of kind of a lens of sexual wellness and sexual illness, sexual focus. So it's for us as women, I know a lot of our urologic issues really touch sexual wellness, and that's an area that we just don't really talk about and don't really focus on, and it's really important. So that'll be kind of the angle of our talk tonight. So here we go. So why talk about it? So it's important. It matters for relationship wellness and physical wellness, and it's something that's not taught in residency, and is something that we really want to be able to focus on. So here we go. Just another data point here, 14% of women will visit a doctor for sexual function related issues, and many of us have them. So we are not going to not be afraid to talk about it tonight. So focus of my talk this evening, we're going to talk about pelvic organ prolapse. We'll focus on incontinence, pelvic pain, a good amount of time on genitourinary syndrome of menopause, which is a super important area for us, and then interstitial cystitis, and a little time on hypoactive sexual desire disorder towards the end of the talk. And so why do urologic issues cause sexual dysfunction for us as women? Well, here it is. Our anatomy is the answer. And so if you look at this schematic, kind of looking inside our pelvis as women, you can see right away that the bladder and the vagina are right up next to each other. And so if you have an inflammatory problem or structural problem, that it is definitely going to affect you in the sexual sphere of your life. Okay, so we'll start talking about incontinence here. So I've, at the beginning of each of these subsections, I've used a quote from a patient. And so this is a common quote. I was in clinic this afternoon and I got this from multiple patients. So a big concern for all of us is having a leakage event during intercourse. That just is terrifying to a lot of us. So what is urinary incontinence? So urinary incontinence is leakage of urine. And when we talk about urinary incontinence, we try to be really specific, and we try to put it into one of two categories. So we have stress leakage. That's leakage that happens during an event that increases pressure in our belly. So classic example would be coughing, sneezing, lifting something heavy, jumping on a trampoline, chasing your kid down the road. That's going to be classic stress leakage. The other kind of leakage we can have as women is urge leakage. And that's when, we feel strongly that we have to urinate, we have that urgency, and then before we can make it, before we can get the key in the door of our house, before we can get out of our car, here we go, the urine comes out. And so for both of these kinds of leakage, these can play during sexual activity. The pressure on the bladder can cause bladder spasms and can cause leakage. And then if we can't squeeze that urethra off, the pressure on the belly during sexual intercourse can cause leakage too. So we can see both of these particularly affecting sexual function. So first, to narrow focus on stress incontinence, again, that's the leakage that happens when we increase pressure in our belly. And, a common reason that this happens to us is because of a vaginal delivery, multiple vaginal deliveries, a vaginal delivery of a large baby. I see it in women after pelvic surgery, hysterectomy. And then I see it in women that have never had a pregnancy at all. I have women that I've taken care of who have terrible stress leakage. They've had it since they were quite young and not related to that at all. So there's probably a genetic component going on there. But stress incontinence, incredibly common issue for us, affects 1 out of 3 women over the age of 45 and massively undertreated. So what is stress leakage? So this is a diagram I tried to put up here to explain what should happen and then what can go wrong. So essentially, you've got your bladder here, and you're going to have some pressure transmitted to the bladder from the outside. So you lift something heavy, you cough, you sneeze, that's going to start to push urine out of your bladder. And then you've got the green arrows coming in from the side. That represents your pelvic floor. And then the closure kind of layers in the urethra, trying to pinch that off over just that very short length of our urethra. And so if you don't leak, that means that you can generate enough force at that green arrow to hold the urine back. But for many of us, that's not true. So for many of us, it's this next scenario where the pressure is pushing down on our bladder and we just have inadequate closure force. And there we go. Our bladder opens, our urine starts to leak out, and we have a leakage event. So what can we do about stress leakage? So some women can manage this without procedures. There is no medicine that I can offer women for this, unfortunately. What we want to do to stop stress leakage is increase the pressure at that urethra. And unfortunately, there's no pill that can do that. Some women find that they can decrease the amount of pressure pushing down if they lose some weight. There have been some nice studies that have been done that show that if you do lose some weight, that can improve both stress and urge incontinence. Stopping smoking is important because of chronic coughing, right? If you're coughing, that's just pressure on your pelvic floor and you might leak. Our pelvic floor physical therapy colleagues can work with patients and essentially do exercises to help strengthen and coordinate those pelvic floor muscles so we can pinch off that urethra more tightly. And then the last non-surgical option is this picture that I have on the screen. So this is a pessary. Pessary is an object made of silicone. The most common one I use is this one picture here. This is called a ring with a support. There's a particular pessary that has a knob on the top of it, and that's what this one is. You can put that knob, you can put the whole pessary in the vagina, and you put it in so the knob is facing up and pushing up on the urethra, and that can put some support underneath the urethra and apply a little more force to the urethra and let women not leak. So again, this is overview of non-surgical options for coughing, sneezing, stress leakage. No pills, some lifestyle modification, working with the pelvic floor physical therapist works wonderfully. And then a pessary for a particular woman who feels that kind of matches her goals of care. So now we have surgical treatments. So historically, there was a procedure called a birch that was done through the belly. It was an open abdominal surgery, and sutures were used next to the bladder neck to kind of elevate and support the bladder neck, realign the urethra by all of the pelvic floor, and help increase closure force. That was actually a surgery that I did not learn to do in training. I do know some of my colleagues actually have transitioned that to a robotic approach. So that's actually very interesting to me. But the most common stress incontinence surgeries in America, what you're going to see, what I offer patients are the numbers 2, 3, and 4 on this list. So most common stress incontinence procedure in America is the mid-urethral mesh sling. That's a small piece of mesh that goes around and underneath the urethra to kind of support the urethra underneath and improve that closure force we talked about earlier. You can also make a sling out of not mesh, but your own tissue. And so most commonly what that means is we harvest a piece of tissue from the lower abdomen, kind of like very similar to a C-section. That's the sort of incision that's made. The piece is 2 centimeters by 8 centimeters, and then that can be passed around and underneath the urethra again to support things. And then the newer option in this space is the idea of a urethral bulking agent. There have been, maybe 8 or 10 products on the market over the years. The newest one has been on the market since 2021. It's a product called Bulkamid that is a polyacrylamide gel that's injected under the lining. And that is actually a really exciting option. That's probably the most common procedure I've been doing in the last 2 years. For stress incontinence for reasons that you'll see in a minute, but kind of big overview of surgical options there. So first, to kind of dive deep into the mid-urethral sling. So again, a side view of our pelvis as women. You see the bladder and then the urethra, and then you see the vagina behind that on the left. So with the sling, I take patients to the operating room. They are totally asleep under general anesthesia. A small incision is made in the anterior vaginal wall. And then I make a little path around and underneath the urethra, and I pass my little piece of mesh, my sling. It goes from above the pubic bone and the lower belly, and then dives behind the urethra and comes back up. So if you could look at this pelvis from the front, you would see that the sling is going to make kind of a hammock or a U shape. And the idea, again, is that mesh is underneath the urethra, supporting things, allowing all of the pelvic floor to be in alignment so we get nice closure. The incision in the vagina is closed by dissolvable stitches. These little openings in the belly are closed by usually just a little dot of surgical superglue. And then you have to have pelvic rest so this incision in the vagina can heal. Typically that takes about a month. And that pretty much is an overview of a sling. The things we worry about here with slings, largely erosion of mesh into the urinary tract, which is a disastrous complication. It's fairly uncommon, but every now and then it does happen. And if you do enough slings, you do see these complications. So I've seen them. And so for me, that's why I was very excited when this new bulking agent, Bulkamid, came on the market, because it's a less invasive option that achieves very comparable results and avoids and reduces these risks of mesh-related sling complications. So let's see. So, and here we go. So, well, what about mesh? Every time I talk to patients about, slings and mesh, this comes up every time. And I understand, there are all these billboards everywhere you look. So this whole issue with mesh came about actually from surgeries that were done for prolapse. That's when, and we'll talk about that later, that's when the bladder is hanging out of the body, when the vagina is kind of trying to come inside out. About 15, 20 years ago now, there are these mesh kits that came on the market that were put through the vagina to put the bladder, the vagina back up into our pelvis. And those were put in blindly. And there were all sorts of issues with these mesh kits. They would erode into the vagina. They would be placed into other structures. And so those have all long since been pulled off the market. By the time I was in residency, which was 15 years ago now, starting out, those kits were already being pulled off the market. I have never actually even implanted any of them. I've only dug that mesh out. But because of that fiasco with mesh, that touched all of surgical mesh, sling mesh, hernia mesh. And so slings got re-reviewed extensively. And so this is a really nice position statement that should you be considering a sling or want to know more, you can click this PDF and it will download the entire position statement you see on your screen, and you can save it. But really kind of nicely goes through the literature. Slings are safe, but there are things that can go wrong. We do know how to manage them. And I think ideally we just try to make sure that we're doing the right operation for the right patient to minimize as much as possible exposure to these complications that can happen. So, okay. So that's a nice transition to Bulkamid, which again is in that urethral bulking category of procedures that I do for stress leakage. And so we have a little video that we're going to play here. And really, it's going to illustrate how this is done. So again, our urethra as women isn't but 4 centimeters long. So with Bulkamid, with a patient asleep in the operating room or sedated, I look in the urethra at just about 2 centimeters, and I have a little needle that I pass under the lining of the urethral wall, and I inject little blebs of this water-based gel. I do them in all 4 quadrants, and I inject them so they kiss in the midline. And the idea there is that everything can coapt and you can have good closure force and not leak. And from a patient perspective, it's a needle stick. So a little burning when you pee, and there's no downtime, there's no incision, there's no mesh. So I really like Bulkamid to start for most patients. And if I can fix people there, that's fabulous. And then I save my slings for my Bulkamid failures. Also with the Bulkamid space, if I can get someone 75% better, I can always take them back and inject a little bit more. So just probably my preferred stress incontinence treatment at this point. So we're going to go ahead and play this video. It's about 1.5 minutes long. Some of it is just background on stress incontinence, which we don't really need, but there's a really nice animation of Bulkamid. So I just think that's helpful to see.
Everyday activities like walking, exercising, Enjoying a day out with the family, or even laughter can cause anxiety about leaks. But you don't have to live with the symptoms of SUI. You do have a choice. You don't have to suffer in silence and put up with a life of wearing pads. If you leak urine during daily activities, Bulkamid can help provide the relief you've been longing for. The short, incision-free procedure typically takes less than 10 minutes. Involves 3 to 4 small injections of soft, water-based gel into the wall of the urethra to help prevent urine from leaking out of the bladder during day-to-day activities. It's safe, quick, and most patients can get back to your normal activities almost immediately. In a clinical study, 92% of women reported their bladder leaks were cured or improved after their Bulkamid treatment. Bulkamid is available around the world. Ask your healthcare provider today. Bulkamid, the SUI treatment option preferred by women.
Okay, so there you go. But really a fabulous option for stress incontinence. Just a really nice postoperative experience there for patients. So I'm a big fan. Okay, so transition. So we're still in the I leak urine category, but now we're transitioning to a different kind of urinary leakage. So this is urge leakage. This is the urge to go hits you. You pull in your driveway, you see the toilet, you hear water running, and darn it, you're trying to kegel, you're trying to squeeze, but you just cannot stop the urine from coming. So here we go on this topic. So generally, we call this overactive bladder. So overactive bladder, constellation of symptoms, including urgency, frequency, and then leakage of urine. And so essentially what's going on here, totally different setup than stress leakage, where it's really a failure of our pelvic floor. With overactive bladder, I like to explain this as a signaling problem, right? So you've got your bladder. It's a bag, a potential space. It's got muscle in its wall, and it's got nerves built into the wall. So you've got urine coming down, your bladder fills. And what's supposed to happen is as your bladder fills, that message is supposed to go to your brain, inform your brain of how full or not full your bladder is. And then, as you know, when you start to perceive fullness, then you decide to go to the bathroom. You send a message from your brain to your bladder to go ahead and squeeze. With overactive bladder, this is going wrong. The bladder is sending signals to the brain. I'm full, I'm full, I'm full. It's a lie. It's not true, right? But you can't, your brain can't differentiate the truth from the lie. It just knows what it's told. And then for some people, it even goes a step farther. For some people, the bladder muscle will actually squeeze, and you're in Target, you're in church, you're not ready. Again, looking at that drawing of anatomy we looked at earlier, our continence zone, our urethra is so short. So if our bladder starts to squeeze and we're not ready, we are going to have a problem. And so that's kind of this overactive bladder picture. So what causes this? Well, for a lot of people, we don't know. That's what idiopathic means. I do see in my patients a very high penetrance of back disease. So I've had back surgery, I had a back injury, I was in a car accident. And that makes sense to me medically and clinically, because anything in your back that's going to interrupt that signaling process between brain, spinal cord, pelvic nerves, and bladder. Another common cause of overactive bladder is bladder irritants. So anything that you put in your body, you drink it, you ingest it, you smoke it, you eat it, it's going to end up in your pee. And if it's irritating to your bladder, it can cause this whole constellation of symptoms. So today in clinic, I talked to several patients about this today. And today, this theme was acidic things. You know, a lot of people having issues today with lemon juice, citrus fruits, tomatoes, just a lot of bladder pain. So that's an example. Other common irritants are going to be caffeinated things, artificial sweeteners, red dyes, red wine for some people. So real patient-dependent thing. There's some people that can have lots of those. They have no bladder symptoms, but for some people can cause real issues. Constipation can cause overactive bladder. Stress. I see a lot of people manifest stress as urinary frequency and urgency. I mean, we all remember when we had to give presentations. It's probably happening to me right now, where you get nervous. You feel like you have to pee 10 times before. You don't really have to pee. Your bladder's not really full, but it's that manifestation of nervousness, right? And then menopause, another lack of estrogen in our body. Our estrogen levels plummeting. There are estrogen levels in the trigone in our bladder, and so as we go through menopause, that lack of estrogen, big trigger for overactive bladder for us as women. So what can we do? So I've kind of alluded to all these things. So for some of us, we can look at our choices. We can make different choices, and that can help. So increasing water, avoiding caffeine, a bladder irritant, evaluating for bladder irritants, treating constipation. By the time people get to me, usually they've tried these things. And so we start with medications. There are two medicines that I commonly use. They are in the beta agonist, beta-3 agonist category, work really nicely. One is called Myrbetriq, one is called Gemtesa. I probably improved 60 or 75% of my overactive bladder patients just with the simple medicine, prescription medicine. Vaginal estrogen therapy, very helpful for all of my peri and postmenopausal women. So definitely that goes in here. And then for my more refractory patients that only get a partial response to medicine or get no response to medicine, we have third line options that are procedures. So in that space, we've got Botox that we all know for our foreheads. We can also inject that into the bladder. We've got a bladder pacemaker, as I call it. That's called sacral neuromodulation. There are two companies that make that, the Medtronic InterStim device and the Axonics implant. A new area are these ankle implants. These are all just getting FDA approved in the last year or so. One is called eCoin, one is called Revi, and then there's an office-based treatment called PTNS. So I'll kind of run through all four of those procedural things. So first, Botox. Botox is a neurotoxin. It's botulinum toxin. Its mechanism of action, wherever you inject it, forehead or anywhere else, you put it into the muscle, and where you inject it, it's going to paralyze that muscle for, 3-4 months on average. So in your forehead, that's why your wrinkles go away. You can't move your forehead anymore. So in the bladder, again, with this drawing, I would look in the bladder with the telescope. Sometimes I do this with the patient awake. Sometimes I put numbing medicine in the bladder to kind of deaden the inside of the bladder if a patient wants to be awake and so they don't perceive pain. And once I'm looking in the bladder, I have a tiny little flexible needle that I pass through my telescope, and in 10 small spots, you see the little dots I made on my diagram, I inject a very small amount of this Botox medicine in kind of a grid pattern. And I see people back at 2 weeks, and we see if that paralyzed enough of their bladder muscle to calm down their overactive bladder. Big risks of Botox, the biggest one is retention. So I am paralyzing a small amount of the bladder muscle. That can mean that people can't adequately empty their bladder, and then they could be stuck with a catheter for a period of time until the Botox wore off. That is a small risk, not but a couple percentage points, but very difficult to predict in the office who it is. So I very frankly talk to patients about this. But that said, I have many patients that get Botox. I've got it for years. It's a fabulous option for management of overactive bladder. So sacral neuromodulation. So this is the bladder pacemaker. So when I think about Botox as kind of looking at this system that's gone wrong, where we have the signaling problem, and essentially we're going to fix it by just telling the bladder muscle to ignore the signals. Sacral neuromodulation is kind of a different way of looking at it. It's kind of like saying, well, we've got a signaling problem here, and we're going to fix it by actually stimulating the nerves and making the signals go through make sense. So in our lower back, we've got our sacrum bone, which is this upside down triangular bone. There are openings in that bone. In the third opening, that's called the S3 foramen, that's where the nerve root to the bladder runs. And so in the operating room, I can look at this anatomy with the patient awake. I can find that exact spot on their body. I can numb up their skin. I can pass a needle through that opening, kind of as you see where the little dotted line is on that man. And I test motor responses or sensory responses, and that's how I know that I'm in the right spot. I pass a little wire through that needle. I pull the needle out and I connect it to a battery, and I just tape that onto someone's back. And for a week, they're going to wear this temporary device. It's going to stimulate their bladder nerve, kind of like test driving a car. And at the end of the week, they'll know, does this therapy fix my problem? Yes or no. At the end of the week, they come into the office. I pull that dressing off their back. I pull that wire out. We throw it away. They're no worse for the wear. But if it was helpful in terms of their urgency, their frequency, their urge incontinence, we can actually also use this for fecal incontinence. We would go back to the operating room and implant a permanent version. And so what you see on this picture, the the picture that's on the left hand of the screen in the gentleman's hands, those are the batteries. One is a rechargeable battery, the small one. The larger one is a non-rechargeable battery. That's a Medtronic device. And then at the bottom of the screen, those are the Axonics devices. Those are blown up. They're actually a little bit smaller than the Medtronic devices. And that green key fob is actually the controller. So it's a therapy that I find is very confusing for patients. It's difficult to understand exactly what it is, but once people have a trial, it really crystallizes how it works and really kind of how amazing it can be. Makes it a little bit more approachable. So sacral neuromodulation there. And so now we're kind of going to peripheral therapies. So PTNS is an office-based therapy where patients would come in. We offer this in our Norwood office in Cincinnati. And so you would come in, we put what's functionally like a little acupuncture needle in the inner side of your ankle. That's where your nerve is, your tibial nerve. And we put, again, an electrical impulse into that nerve, just kind of like we were talking about with the sacral neuromodulation therapy. And so you sit in the office, have this treatment. It's done repeatedly. And so this is a therapy that's been around for a long time. It has great results. It's just hard, I think, to ask people to come sit in our office, even though we're all very nice people and charming. We all have a lot to do. We're all busy. And so for a patient where maybe they live by Norwood, this is a great option. If you want to come visit us here, we'd be happy to see you. But this is really the impetus for the next slide, all of these implantable ankle devices that are kind of coming off the market. And so this is kind of the new evolving area in overactive bladder. So let me go there. So essentially it's like, well, we know stimulating this nerve in the ankle works, but no one wants to sit in the office. So how do we bring this therapy to people so they can have it? So these are two different devices that are both actually FDA approved now. The one that looks like a Christmas light fuse in the right upper corner, this is a device called Revi. And so that little implant is implanted in the ankle. You see this gentleman with the watch kind of thing in his ankle. So that would be implanted under the skin there, right along the tibial nerve. That incision would heal. And then a patient at home can stimulate their tibial nerve by wearing this ankle bracelet. So this just got FDA approved, oh gosh, maybe 3 months ago now. I'm actively trying to get this at our premier Middletown Hospital and a couple other ones. But this is a hot off the press option. And then this one down in the right lower corner, this is called eCoin. And you see why they named it eCoin, because it's about the size of a nickel. Same idea, though, implanted into the ankle. Different than this Revi device, this one is all self-contained. So there's no watch kind of thing that you have to put on to stimulate the nerve through the skin. Once the device is activated, it just goes and stimulates the nerve every 3 days for a preset period of time. Okay. All right, so transition here. Lots of talking from me. We're going to talk about pelvic organ prolapse now. Okay, so super common complaint, again, that I hear from my patients. So women come in to see me and they say, I haven't been sexually active in 6 months. You know, I just had this bulge, and is it going to fall out? Is it going to burst? What is my partner going to think? My partner saw it. I hear all of these things about prolapse. And this is actually a really common reason that women come talk to me about prolapse because of its impact on their sexual life and kind of transitioning to them not being sexually active when it's something that they would want to be doing. So what is pelvic organ prolapse? What is your pelvic floor? So this is, again, side view of our pelvis. So pelvic organ prolapse simply means that our pelvic organs, our bladder, our vagina, our uterus, our rectum, that those organs, instead of being suspended up inside us like they are in the upper picture, they're trying to come out. And that can happen because the vagina really is just a potential space. It's an opening in our body. And so if any of those organs lose their support, they can kind of cannibalize that empty space. They can push out, and that's what happens. Why doesn't that happen? You know, what is the support? So we have all different layers of support. Our pelvic floor really is a collection of muscles and ligaments and fascia that kind of act as a hammock underneath all of those pelvic organs. And then we have additional kind of structural support that comes down. The blood vessels that go to the uterus provide support. And so it's really a very complicated thing. And so these are pictures on this slide of how it can go wrong. And so I think the language can be really confusing. So I'm going to spend a little time and just explain that. So pelvic organ prolapse globally means, again, that our organs that should live in our pelvis are trying to essentially exit our body and go to the outside world. And so what is a cystocele? A cystocele comes under this umbrella of prolapse. A cystocele means that the bladder is pushing down and through that front wall of the vagina. And in some cases, it's just present right at our vaginal opening. And so we can kind of maybe perceive a little bulge when we're wiping. For some of us, it can come all the way out of the vaginal opening, and there'll literally be like a pink kind of clementine or orange sized ball coming out of the vagina. And that could be the bladder if it's coming through that anterior vaginal wall. The next one is called a rectocele. So that's where our rectum is pushing through the back wall of our vagina and again, trying to come out to the outside world. And, again, it can be very difficult unless you do an exam to figure out what the bulge is, but it could be bladder and or rectum. Uterine prolapse, the uterus should live at the top of our vagina. And I saw a patient today where we did an exam, and her cervix, which is the bottom portion of the uterus that contacts the vagina, instead of that being as deep in her body as possible, the cervix and the vagina and the uterus were out of her body. And then a vaginal vault prolapse, that's what happens for us if we've had a hysterectomy, and you can see in that picture there's no uterus anymore. And in that situation, the vagina is just kind of like a sock, if you think about it that way. And with vault prolapse, it's almost like someone reached inside that sock and grabbed the toe from the inside and just pulled it out and everted it. And it can literally come all the way inside out. So all of these are prolapse. And then there's specific kinds of prolapse with this language that we use, just depending on what's moving. So prolapse, again, just like incontinence extremely common, prolapse extremely common by 81 in 2 women. Now, that doesn't mean that 1 in 2 women need surgical therapy for prolapse, but have some degree of prolapse on exam. So what are the symptoms? How would you know? I ask all of my ladies, do you think you have prolapse? Do you think you have a bulge? And they go, my goodness, how would I know? Well, you would know because you have a bulge that you feel, and usually that's the degree where if it's that far out of the body, that's where it's really going to impact you functionally. We're going to have symptoms from it. And so what are the symptoms? Heaviness, pressure, feeling like your bottom is falling out, feeling or seeing a bulge. It can cause painful intercourse. It can make it really hard to empty your bladder because, again, you saw in the picture, the bladder can be so far down that you have some urine that sits in there, and that can predispose women to recurrent urinary tract infections. A lot of my prolapse ladies tell me that they have really severe or uncomfortable pain in their lower back, kind of, I think, from the traction of that bulge, leakage of urine. And then some women actually, both to have a bowel movement or to empty their bladder, if their prolapse is more significant, find that they actually push it back in their bodies to be able to empty their bladder, empty their bowels. Why does this happen? Lots of reasons. Again, vaginal childbirth, pregnancy, aging, obesity, pelvic surgery, because it's going to disrupt some of that support we talked about coming down. A lifetime of heavy lifting, chronic constipation, chronic straining, all of these things over time can kind of beat on that support structure and let things come out of our bodies. And then certainly genetics, connective tissue disorders play a role here too. Okay, treatment. So huge spectrum of treatment options for pelvic organ prolapse. You do not have to treat pelvic organ prolapse. I see many women, maybe their prolapse is lower grade, not that bothersome. They have no symptoms. We observe it. You don't have to, we have to have, when I talk to patients, I really feel like it's important that we have a targeted outcome, something that we're trying to achieve. And so if a woman has a bulge, but she's emptying her bladder fine, she has no infections, she has no pain, it's not impacting her quality of life, it's totally something that can be observed. And I regularly do that. I do find some women that have lower grade prolapse do respond to pelvic floor physical therapy, working on those muscles, that pelvic floor strength. I do see women with mild prolapse have improvements. I've had women just do Pilates and do core strengthening on their own and notice that their prolapse improves somewhat. Again, we talked about a pessary earlier. A pessary is this medical grade silicone object worn in the vagina, kind of ideal, kind of think about it as acting as a floor to hold organs in. And so that can be a really nice option. A pessary must come out and be cleaned. So some women, because of arthritis issues, because of dexterity issues, find that they really struggle to do that. So sometimes women come in and I clean it and we put it in and out for them in the office. If we can get a perfect fit with the pessary, it shouldn't fall out. It shouldn't be uncomfortable. It should just work and kind of be magical. So that is a nice non-surgical option for higher grade bothersome prolapse for women. Again, all women need vaginal estrogen cream if they're peri or postmenopausal, especially in this situation. You want to use a vaginal estrogen cream to protect your vaginal tissue. If you're using a pessary, you would certainly want to use vaginal estrogen cream to protect the tissue if you're going to have surgery to promote healing. Which is a nice transition here to surgical treatment for pelvic organ prolapse. So there is a handout that popped out there that talks about robotic sacrocolpopexy that you can save if you like. But so surgeries for pelvic organ prolapse kind of divided by approach and divided by maintenance of the ability to have intercourse or not. So for a woman with bothersome high-grade prolapse, a surgery can be done through the vagina. Now, this is what I alluded to earlier with those mesh kits. So those mesh kits are gone. So a transvaginal surgery, that would be an A&P repair. Some people refer to this as a bladder tack. That's going to be a surgery that's done with you asleep. We look in the vagina and say we're going to do an anterior repair. That means that the bladder is coming down. An incision is made in the top wall of the vagina. I dissect out to each side to get to that tough tissue that should be underneath the bladder holding it up. And I pull that tissue together under the bladder and close it up with sutures. The same thing can be done on the backside for a rectocele. That surgery is a nice surgery. It does not use mesh. Big issue with that surgery is it does have a fairly high recurrence rate, and always has, which is why those mesh kits were used 15, 20 years ago. The surgery that I do most commonly to maintain a woman's ability to have intercourse, but also put her bladder back in her body, is a robotic surgery. It's called a robotic sacrocolpopexy. And so that is a surgery, again, totally asleep in the operating room. Little incisions are made in the belly, kind of in a rainbow shape around the belly button. And I look into the abdomen and look into the pelvis from the inside. I dissect out the vagina. I dissect out the bladder. I dissect out the rectum. I see all of the anatomy from the inside. And I use a Y-shaped piece of mesh. Here's the mesh word. And that goes around the top of the vagina. And then the tail of the mesh is sewn to a ligament of the sacrum. And so that's this picture that you see on your screen here. And so what that's actually doing is it's restoring the normal axis of the vagina in the body in a durable way and maintaining the ability to have intercourse. So the obvious question here is, well, why doesn't this cause mesh issues? Why don't we see the mesh issues with this that we saw with those kits? Well, the difference is approach, right? So with this surgery has been around 40, 50 years. They used to do it through a big open incision. The robot part is new, but it's the same surgery. This mesh is it's like a custom job, right? The mesh is put in, it's cut and trimmed to fit, it's secured in place. It's not going to go somewhere you don't put it. So we don't see the issues with those mesh kits that we saw here. Now, certainly could there be, an issue with bowel injury or mesh infection? You could, but those are very, very uncommon things. So common, a very durable surgery I do, robotic sacrocolpopexy. And then another actually very common surgery I do, now this is going to be for my older ladies, my not sexually active ladies, is a surgery called a colpoclysis. That's a surgery where I go in the vagina and I close off the vagina from the inside. A highly durable surgery, does not use mesh. Outpatient, takes about 40 minutes, minimal post-op pain, minimal recovery, highly durable, but only for the woman who is certain that they are done having penetrative intercourse, because literally from the inside, the vaginal canal is obliterated. Okay, prevention of pelvic organ prolapse. So I think honestly, for some of us, I don't know that pelvic organ prolapse is totally preventable, but like everything in life, like everything in medicine, our choices do play a role. And so again, having a good, strong core, good pelvic floor strength is wonderful for a variety of reasons. So I'm very for that. Maintaining a healthy weight, that's just going to decrease the amount of pressure on your pelvic floor. Smoking is related to wound healing, supportive tissues, many reasons not to smoke. Here is another. And then just kind of maintaining good form with lifting, trying to, again, not to beat on your pelvic floor. Okay. Recurrent bladder infections, another big topic in female urology and very common in my clinic. So um, this is again comments I get from patients. They just know and they come in. I don't want to have sex with my partner anymore because every time, like clockwork, we're sexually active, I get infection, and I just don't want to deal with it. So we've just stopped having sex. That I just hear that all the time. So what can we do for recurrent bladder infections? So this is a difficult space. And so the reason that we see infections in the urine really changes as we progress through our lives as women. In childhood, and this can be for boys too, largely infections in the urine in a recurrent fashion, especially if they're febrile infections causing fever, these are related to anatomic issues or related to voiding dysfunction. So kids learning how to modulate their bladder, understand the signals their brain is telling them, managing constipation. That's really what plays in this space. Then we get older, we become sexually active. For some of us, that really triggers a spate of infections. And so I really personally believe there's something about the genetics that some of us have where our bar for infection is just lower. Because I talk to many women and, we all know to get up after intercourse to empty our bladder. And for some of us, we don't do that. We have no infections. There are other women I speak to that have very elaborate rituals for cleanliness, and it just does not matter. And I think really that comes down to genetics. I think their personal threshold is quite low. And so in that space, I really do like for women a low dose post-coital antibiotic, culture driven. So with sexual activity, single dose of antibiotic. If that's the cause of infections, highly, highly effective for UTI prevention in that space. And then as we transition to perimenopause, postmenopause, this is when hormones and other things really come into play. And so as our estrogen levels start to fluctuate, estrogen is key for pelvic wellness. Estrogen is critical for maintenance of healthy vaginal skin, maintenance of normal pH, maintenance of the normal microbiome in the vagina. And so as our estrogen levels fluctuate and then bottom out in menopause, this is why we see a huge increase in urinary tract infection. And then as we progress on in our lives, if we start to have incontinence, if we start to have mobility issues, if we have diabetes, all of those things just, again, change our personal threshold for infection. So again, how can we intervene? What can we do? So for my premenopausal woman, habits like we talked about can help. There's some literature for cranberry as a supplement. Cranberry has an active ingredient in it that can block the binding of E. coli to the bladder wall if it's present when you're exposed. So this does not mean you have symptoms, you take cranberry, it's going to make it go away. The cranberry would have to be there when the bacteria comes in. D-mannose is a sugar that was also used for this. Unfortunately, there was just a paper published in JAMA, I think a week ago today, randomized control trial looking at D-mannose for prevention of urinary tract infection and found that it did not prevent infection. So no longer recommended for prevention of urinary tract infection in this space. And then, as I had mentioned previously, I love for the particular patient where that's their history. If that's your history, I love a postcoital antibiotic. Much preferred to do a single dose of antibiotic immediately after intercourse for prevention. Would much rather do that than a week of treatment strength antibiotics that's going to give you a yeast infection and potentially expose you to more resistant organisms in that manner. For my peri and postmenopausal women, I keep beating this estrogen drum. Vaginal estrogen, so important. And then in my older ladies, really, regular and complete emptying of the bladder. Our drive to drink water, I should drink some right now. Our drive to drink water as we get older really goes down. And if you're not drinking, you make less pee, you get full less often, the urine is sitting in the bladder. And as women, we're going to get bacteria in our urethra. It's so short. So increasing fluid to promote regular emptying is really important. And then UTI vaccines. So in Europe, I think coming soon to Canada, there is a sublingual daily UTI vaccine that has pretty amazing results, not yet available in the US. I really want this. So hopefully that's coming soon. Yeah. Okay, so nice transition. So like I said, I've been beating my drum about estrogen. So here we are. So for us as women, There is a syndrome that was recently renamed. We used to call it atrophic vaginitis, but now to really bring in all of the facets of lack of estrogen in our pelvis, we call it the genitourinary syndrome of menopause. And so that includes this whole list of symptoms: vaginal dryness, painful intercourse, irritation, itching, tenderness, urgency, frequency, peeing at night, leakage of urine, recurrent bladder infections. So this is a syndrome that happens to us when our estrogen is low. So some of my patients, some women will experience this even after delivery of a child. When our estrogen levels are really low during breastfeeding, some women will have this clinical picture. But certainly we start to see this in the perimenopausal zone of our life. And then once we hit menopause, no more periods. So common. And so this plays for urinary tract infection because that microbiome, that pH of the vagina is critically important for UTI prevention. And so fixing that, maintaining that, literature suggests that can get rid of probably about 60% of postmenopausal urinary tract infection, which is a pretty staggering number. Okay, so here I am with my Oprah meme. Everyone gets estrogen. So a vaginal estrogen is different than hormone replacement. Okay, so that it's a question of dosing, but it's different. So this is important because there is this fear and anxiety around giving estrogen to women related to cancer. So I just want to be very clear here. So hormone replacement is when we give a woman estrogen or progesterone or testosterone or all three, right? But we're putting those hormones back in the body, in the bloodstream, so that they're present everywhere in us. When we're talking about pelvic health, I mean, hormone replacement is great, but what we really need is estrogen in the vagina, right? And so that's local therapy. Local therapy really does not have any systemic exposure. And so in that space, as women, we have two different options that I most commonly use. We have a vaginal estradiol cream that's applied to the skin in the vagina. And then we have a little vaginal estrogen tablet. That's this insert that's injected into the vagina. So both of those, the estrogen goes into the skin, and it's kind of like lotion for the vagina. With 6 weeks of regular use, you're going to restore that microbiome. You're going to fix the architectural changes that we see in the vagina, and really improve and reduce your risk of all of the symptoms of genitourinary syndrome of menopause. And so I did have a question. I'm skipping one. I'm going to come back to it. But can you use a vaginal estrogen cream if you've had breast cancer? Yes. So we have a lot of data in this space. And so if you are a breast cancer survivor and you are, let's say, 10 years out of diagnosis, 15 years out of diagnosis, you are off an aromatase inhibitor, you're just being followed. We have reams of data in that space. Absolutely, you can use a vaginal estrogen. It is safe. It is not systemic. It will not reduce or will not increase your risk of breast cancer recurrence. Often, I do discuss with people's oncologists if they're still following, just, out of collegiality, but the data is clear and strong in that space. The data was less clear in the space of an active breast cancer patient recently diagnosed, still on an aromatase inhibitor like tamoxifen. In that space, for a vaginal estrogen, we have one study. It was published in November. It was out of Europe, and I should have looked up how many patients were in it. It was a moderately sized study. In that study, there was no increased risk of breast cancer in the women that used a vaginal estrogen versus the women that did not. So this is an area where we don't have a lot of data. In my heart of hearts, I truly, though, do believe that it does not increase the risk of breast cancer recurrence. But this is an area where, again, we have one study. We don't have 100. So I really talk to my patients. They have to make the decision for themselves, an informed choice. And I definitely talk to their medical oncologist in this point so that we're all on the same page to really counsel about risk. But, like everything in life, it's a balance. If you are tortured by your pelvic health symptoms, and a lot of breast cancer patients are, you have to find that middle ground where you have to maintain your quality of life. And if there is a negligible increase in risk in breast cancer, I find that a lot of women will take that. But again, one study out of Europe, no increased risk of breast cancer with use of a vaginal estrogen in that space. Oh, so another question, how much estrogen should you use vaginally? So the dosing is different based on the product. The vaginal estrogen cream, it comes with an applicator. And so you would use a gram of it 2 or 3 times a week. My patients hate the applicator. You use a lot more than you need. It falls out. It's messy. You got to clean the applicator. Everybody hates it. So what I tell my patients is use your finger, just use a small amount. And with that dosing, I find the sweet spot is 3 times a week. So I say finger, Monday, Wednesday, Friday. And again, make sure you're getting it in the vagina, by the urethra, inside the labia, as deep inside your body as it goes. The vulva, the labia majora, that skin is more like arm skin. You can put that there. It's just you're not going to get the benefit that you will starting at the vaginal opening and going all the way inside. The vaginal estrogen tablet that dissolves, that comes in that applicator on the right side of the screen, that is dosed twice a week. Okay, pelvic pain. I have women come see me, and this pelvic pain, spans all areas of our lives. A lot of the pelvic pain that I see in my postmenopausal women, a lot of it is related to a lack of estrogen. In my younger patients, I'll see more of the diagnoses that are going to come on these slides here. And so what can cause it? So vaginal pain can be present. Some patients come in and say it's all the time. I can't sit in a car. I can't wear tight pants, or it's just during intercourse. I have spasms and I have pain. And so the list of conditions that come in this space is long. So as we've been beating the drum about estrogen, there it is again, our pelvic floor. So we want to increase strength of the pelvic floor to stop leakage, but some of us actually have too much tone in our pelvic floor. All those muscles are tight and clenched, and that can actually cause pelvic pain with intercourse. There are skin conditions, not lack of estrogen, but skin conditions that can cause vaginal pain. There's a pelvic pain syndrome, a bladder pain syndrome that we call interstitial cystitis. I'll talk more about later, that can cause pain. There's an inflammatory hormone-mediated problem called vulvar vestibulitis related to birth control pills that can cause pain. Adhesions of the skin covering the clitoris can cause sexual dysfunction, orgasmic dysfunction, pelvic pain, and many more. I mean, we would be here all night. I could ramble on and on. Obviously, I am already, but lots of things that can cause pelvic pain. And so treatments, we really narrow the treatment by cause and by what we find on exam. And so dryness, again, the role of vaginal estrogen therapy at our Norwood office, which I do not go to currently to our Norwood office, but one of my partners does. There is a Mona Lisa laser. And so that has approval for fixing the skin changes associated with lack of estrogen. It can maintain that tissue quality. For that, again, increased tone in the pelvic floor. That's where our pelvic floor physical therapy colleagues come in big here. I also will sometimes use medicines that we put in the vagina to help relax the spasticity of the pelvic floor. Dermatologic conditions varies very much by diagnosis in that space. Interstitial cystitis, I'll talk about that more later. But again, that's a symptom-directed approach where I'm going to use medicines. I'm going to take people to the operating room. We do all sorts of things to try to give people a management strategy that they can use to manage the pain from their bladder. Okay. And so interstitial cystitis, nice segue here. So interstitial cystitis is bladder pain syndrome. And so this is a diagnosis of exclusion. So you do not have interstitial cystitis if you have recurrent bladder infections or you have overactive bladder. This is something different. So you have bladder pain syndrome if you have frequency and urgency and pelvic pain, but your cultures are sterile. Some women will actually have blood in their urine that they see. They can have pelvic flame from the kind of inflammatory condition in the bladder. And so this can be a very difficult problem. It can cause severe pain and decreased quality of life for my patients. It can be really hard to manage. It is not really a symptom a diagnosis that we understand very well. And so really our treatment at this point is very targeted towards an individual patient's symptoms, what characterizes their IC, and then I really dig in from there to try to calm inflammation down, and then at a minimum give them a toolkit of things that they can try to get their pain under control. Kind of overlapping with overactive bladder here. So stress reduction and then dietary triggers, just like with overactive bladder, that a lot of patients find that really is true here. Patients can figure out what triggers their symptoms. And at least then again, they have something in their toolkit. They know, oh, if it's soda, they can choose to have a soda. They know what the cost of that soda will be. And then all of these other multimodality therapies, as I've kind of mentioned before, pelvic floor PT, medicines, medicine in the bladder, stretching the bladder. And then some patients will actually have inflammatory kind of bleeding ulcers in the bladder, which sounds terrible, and it is. But for my severe pelvic pain patients, I'm almost in a way happy if I see that they have those, because I know I can treat them, and that can really improve pelvic pain and their bladder symptoms. Okay, so this might be our last topic for the evening. So hypoactive sexual desire disorder. So this is a little bit of a transition from, or a little bit different than all of the other female urologic conditions we've discussed that kind of touch on sexual wellness. So this hypoactive sexual desire disorder is when you really don't have any interest in having sex. Your libido is gone, and it's bothersome to you. You're not okay with it. You want to be interested, but you just aren't. And so again, why does this happen? So does seem to be perhaps an imbalance of transmitters in the brain that can play here. So there are some medicines that can cause it. Stress and relationships can cause it. And so again, kind of a multimodal approach here. What a lot of women don't know, and why I kind of wanted to highlight it here, is we actually have FDA approved medicines in the space that a lot of women don't know. So obviously sex therapy is wonderful. Counseling is wonderful. But if you have an imbalance of neurotransmitters in your brain, you need to fix it. And so the first one, flibanserin, the brand name for that is Addy. Addy is a pill that's taken, every night. And when it originally came out, it got a lot of bad press because the labeling was that you could not have any alcohol. And so no women were interested in it, were very limited women, because of this interaction with alcohol. So the reason that labeling was there and is no longer there is because Addy can cause you to feel a little bit sleepy. And so if you drink a lot of alcohol, like they did in the study that they used to approve it, I think it was like, I forget how many drinks, but it was way more than would be appropriate. Maybe it was 5 or 6 drinks. I mean, you are going to be quite sleepy from that. If you put a medicine on top of it, it's going to be worse. So that labeling has gone away. But it's actually nice for a lot of women, because a lot of us kind of perimenopause to postmenopause do have some sleep issues. And so a medicine that makes you a little sleepy, improves sleep quality, kind of a nice side effect to have. And then in about 50% of patients does improve libido. So that is an oral medicine, Addy, that's taken. Bremelanotide is an injection, and it is taken immediately before one would want to engage in intercourse, like that night. Like if you were going to go on a date night, that's when that's used. I haven't used that very much. That can cause nausea, which is just a side effect that no one really wants, frankly. So I like Addy a lot better than I like bremelanotide. Both of those are FDA approved for premenopausal women. They do work for postmenopausal women. They are just off label. So that would be a cash pay situation in that space. And then for my postmenopausal women, there is data, again, off label, but you can use topical testosterone for us as women. And so that's a nice option as well. Okay, so that concludes the talk. So I'm going to go over to the questions. I did a couple of them, and then I skipped some, so I'll just go back in order. So the first question was back about the ankle bracelet. So that was for the Revi implant. That was the little implant that goes in the ankle that looks kind of like a fuse for a burnt out Christmas light. That you wear that ankle bracelet for about 20, 30 minutes in the morning is how most people do it. You do not have to wear it all day. It's not like an ankle monitoring bracelet where you're going to be out in public wearing that. And so there was a question about vaginal estrogen cream for breast cancer. So the answer is yes, you can do it. Just a little bit of a lack of data if you are a breast cancer patient with a more recent diagnosis, still on an aromatase inhibitor, but definitely well-established safety after the aromatase inhibitor. No, we have the Mona Lisa Touch. It is available. Are these issues best addressed by a gynecologist or urologist? I think either. It really depends, I think, on the particular issue. Urology and gynecology have a fair bit of overlap. I would say most gynecologists are really going to be very read in on probably the pelvic pain stuff. The prolapse, they're probably going to do the more vaginal-based surgeries, not abdominal-based surgeries. A gynecologist that's done additional time, urogynecology fellowship, kind of like some urology stuff, they're going to do all the stuff that I talked about tonight. And so really, I think ultimately as the patient, you want a doctor that is trained and that you can talk to and feel comfortable with. That and I don't know that it matters whether it's urology or gynecology, but you just need someone that you feel comfortable with that has the skill set that can help you. Side effects for vaginal estrogen is the next question. So it depends. A vaginal estrogen cream, I would say the most common side effect that I see, well, I don't know that I would say common, but sometimes the carrier ingredient in the cream, so almost like the lotion component of it, sometimes people will have irritation from that. So that's where sometimes I'll switch people from a cream to the tablet, or that's where sometimes actually I'll go to a compounding pharmacy, because a compounding pharmacy can control all the other ingredients. And some people are really sensitive to the base. That's kind of the lotion that's used. Some women will notice a little bit of discharge from the cream, and that some of that is actually physiologic, as that estrogen is fixing that vaginal lining. It is normal for us to have some discharge with a well lubricated vagina. And so that, especially a woman that it's been a long time, that they'll be a little bit thrown off by that. Every now and then when I'm starting a woman with severe vaginal atrophy on a vaginal estrogen, she will very briefly maybe get a little breast tenderness right at the beginning of treatment. And I think that's because the absorption is a little bit more than normal because the atrophy is so severe. That usually very quickly goes away. But with that, I just dose reduce, use less cream less often, and that goes away with time. Can you use topical estrogen if you are still menstruating? Yes. So if you are a perimenopausal woman having pelvic health symptoms, you can still use it. Yes, absolutely. Does the vaginal tablet work the same as the cream? Yes. Yes. I've tried the cream and just don't like it because it's so messy. Yes. I hear this all the time. Yes, absolutely it does. And some women that do not like the cream find that it's so much better. So personal preference for all of us. But yeah, for women where I talk to them, they don't like the messiness or it's falling out. They feel like it's all in their underwear. They're still having urinary tract infections. We look at their skin. They're not at goal. I absolutely switch people to the tablet. Okay. Maybe those are all the questions. I have rambled on for a full hour. I can hardly believe that. So there's one more. If you've had a blood clot in the past, yeah. So again, not systemic. So a blood clot is not a contraindication for a vaginal estrogen. So totally okay. Totally okay. You can do it. I'll give it a minute and see if there are just any other questions that pop in. But I really appreciate everyone for listening to me ramble. This is a little out of my comfort zone, so hopefully I've made sense. It's easier for me as an introvert one-on-one. So, but I really appreciate y'all tuning in and listening, and hopefully this was helpful and informative. And I'd be happy to meet any of y'all in clinic. You want to come visit me in Fairfield or Middletown? Those are the offices I'm at right now. And there is some talk of maybe sending me to Norwood. So maybe coming soon. So already, y'all have a good night. Enjoy the beautiful weather, and maybe see you in the office soon.